Okay, I'll get started again. My name is Michael Levy. I'm a neurologist. I specialize in the area of superficial siderosis. I'm at Massachusetts General Hospital in Boston, and I started my training at Johns Hopkins in Baltimore, and that's where I saw my first patient with superficial siderosis. It was a young man who was going to the operating room for something unrelated, and when the surgeons, they heard superficial siderosis, they just threw their hands up and said, "What is this? We have no idea what this is. We need some help to understand what this is, and if you could help us, that would be great." And of course, I was a resident at the time. I never heard of superficial siderosis. I reviewed the literature. I couldn't find anything about it. It was very frustrating to me, but such a fascinating disease from a scientific point of view that I really took the opportunity to understand what was going on with this one gentleman. And what we did after that was review the entire literature starting from the year 1900 in 20 different languages. Every case report that had been published, we put together in a series, and that's where Kyle quoted you, the 270. That's over the past 120 years. Right now, alive today in the United States, somewhere between 125 and 150 patients. And that's really it. So that we're talking about something that's 50 times less common than Friedreich's ataxia, which is the disease you just heard about, which is a very rare disease. So talking about the rare of the rare, and that's what this superficial siderosis condition is. So on slide 2, what I'm showing here is a slice of the brain. And in the purple outline there represents the surface of the brain. And this is fundamentally an iron overload disease whereby the byproducts of blood breakdown in the spinal fluid attach to the surface of the brain. And what the brain does in response to that bleeding is it doesn't like free iron, so it secretes a protein that binds the iron, and unfortunately that makes the whole complex a little sticky, even though it chelates the iron relatively well. What happens is it then sticks to the surface of the brain, and after that, whenever the iron escapes, it causes damage to the tissue underneath. And so what happens over a period of years and years and years, on average it takes 17 years for the course of this disease to actually manifest. In some cases, like in kids, it can be faster, but for the most part, my patients have a car accident in their 20s and 30s, and then they come in with hearing loss and other problems in their 50s and 60s. That's how slow and progressive this course is. But the number one thing they come in with is hearing loss. And it starts with a little bit of buzzing in one ear and then progressive hearing. And, they're in their 50s and 60s, so their doctors just blow them off and say, "Oh, you'll be fine. It's just some age-related hearing loss." But then as things get worse, especially with balance, they'll get the MRI and they'll have this classic MRI pattern I'll show you later. So on slide 3, what I'm showing here are the numbers of patients. As I mentioned, somewhere between 125 and 150. It does require an MRI to make the diagnosis, and so it's really a disease that's only identified in developed countries. Every time an MRI gets built in a new country, I hear from them about a case of superficial siderosis. So it's probably a little bit more common. The example there is in South Africa when they built their first MRI machine a few years ago. They started finding a couple cases. And so as MRI becomes more prevalent throughout the world, I think the numbers will go up. But in the meantime, it's still considered a very rare disease. On the 4th slide there, what I've highlighted is a cross-section of the brain. This is what happens when you cut somebody this way, open them up, and then look on the inside. And you can see the brain and the spinal cord there. And fundamentally, the problem is that there's a bleed into the spinal fluid. And the spinal fluid is kind of like the blood of the brain. Spinal fluid is made deep in the brain. It circulates all the way around, down the spinal column and back up. And it carries nutrients, sugars, salts, and it carries out all the waste of the brain. And when the bleed occurs into that spinal fluid, normally the spinal fluid is like water. It's perfectly clear. And when you bleed into it, It really disrupts the circulation, number one. It changes the composition, obviously. And most importantly is the iron can't get out. And so the brain chelates it with a protein as well as it can, but ultimately it overwhelms the ability of the brain to chelate that iron, and over time the iron starts to cause damage to the brain. Now, what does this look like on a brain MRI? Well, on slide 5, I'm showing you 3 cuts, which are cuts like this through the brain. So it's like chopping off the head and looking down. And what you can see there, the stuff that the arrows are pointing to, those heavily blackened areas, that's iron deposits. And the iron can bind wherever it sticks, wherever it is. So if there's a lot of bleeding in the internal part of the brain, then that's where a lot of the iron will be. And if it occurs somewhere in the spinal column and it circulates up into the head, it might deposit in the back of the head, it might deposit on the front of the head, it might deposit in the spinal column. And wherever the iron is, those are the symptoms you have. So if the iron deposits around the nerves going to the ears, as it does in many patients, they get hearing problems. If it deposits in the back of the brain, that's the coordination center, so they may have trouble with balance. And if it binds in the spinal column, they may have weakness, numbness, and bowel bladder problems. Now, MRI is the most effective way of making the diagnosis, but on slide 6, the old-fashioned way of making the diagnosis was doing a lumbar puncture. This is a procedure where a needle is inserted into the spinal column and spinal fluid is withdrawn, and like I said, normally it looks like water. It always amazes patients to see something like water coming straight out of their back, but that's exactly what it should look like. And in cases of superficial siderosis, it's not bright red blood because this is spinal fluid that's diluted the blood. So there's usually just a little bit of blood that bleeds at a time. And so it's yellowish. That's the color of the spinal fluid. And that's how we can tell that there's bleeding going on. And every time you do a spinal tap on these patients, you see continuation of that yellowish fluid because they never stop bleeding. And over the course of years and years and decades, and the iron buildup over that period of time, that's what eventually causes the problems. Now, on slide 7, what I'm demonstrating is the most common site of the bleed, which is in the spinal column. It's usually somewhere around here. And there's a lining around the spinal cord called the dura, which is highlighted there in orange. The dura, well, in gross anatomy class, the dura, when you dissect it off of the bone, is really about as tough as leather. You can't tear it with your 2 hands. You need a knife or scissors to cut this stuff. It's just so strong. And when that tears, sometimes because a bone punctures it or something very traumatic has to tear that dura, then it takes a really long time to heal. And it's very difficult to heal. And as it tears over and over again, it continually bleeds. And the scar that forms around that area is friable, and blood vessels tend to break apart every time it tears again. And that's mostly the site of, I'd say about 70% of all patients have that pathology somewhere in their spinal column. And again, the blood then circulates around the head, and that's why you get the deposits in the brain. On the next slide, on slide 8, again, I emphasize that the course of disease is very slow. And when I teach residents and fellows about this disease, I say, there is no such thing as a superficial siderosis emergency. Okay, this is a very, very slowly progressive disease. It takes years to come on, and as it progresses, it goes over a long period of time. Now, patients do have sudden exacerbations. So after surgery or after an infection or after a fall, they may have suddenly worse symptoms, and hopefully over time, as they get over that acute problem, then their siderosis symptoms also recover partially. On slide 9, I always get this question, and so I really just want to address it right now, which is, does superficial siderosis lead to early death? And the answer is probably not. We don't see an early mortality directly related to the siderosis, but it is profoundly disabling. And so patients do end up completely deaf sometimes, and they can be disabled to the point that they're in a wheelchair all day long even. And if you consider those circumstances, which increase the chance of blood clots and that really increase the ability to live a full life, then yes, I mean, superficial siderosis is not a friendly, easy, mild disease. This is one of those difficult conditions that's hard to live with, and while it may not cause an early death, it certainly makes life very difficult to live. On slide 10, I mentioned 2 tracks of treatment. The first is to stop the bleeding, okay? Because this is a disease that's fundamentally due to the iron deposits from blood, but the actual toxicity is due to the bleeding that occurred over many, many, many years. And so while I do emphasize that it's good to stop the bleeding, it's not going to fix the underlying problem, which is all that iron that's already stuck on the surface of the brain. It can stop more iron from building up, which is a good thing. And so we do approach track 1, stop the bleeding. And that might be surgical. I'll show you the options on the next slide. But before I get to the next slide, I just want to emphasize that even if we stop the source of bleeding, we also need to get rid of the iron deposits that are on the surface of the brain. And so that's approach number 2, which we've used iron chelation medication to try to target. So on slide 11 is the 3 approaches for stopping the bleed. The first is to let a radiologist stick a needle directly into the site of the tear or the pathology or wherever the scar tissue is. They stick a needle in there and then they inject fibrin glue, which is like a biological glue. And the idea is if you immobilize that dura and really give it a chance to heal, then there might be a better chance that it heals permanently rather than forming a weak scar. The second is what's called a blood patch, which is where you insert blood into the lower back, and that basically just pulls the dura off of the bone, surrounds the spinal cord, and immobilizes it for about 3 weeks. And so you get a 3-week opportunity to heal. Sometimes it works if the tear is small, but often it doesn't. And the third option is to go into the operating room and let a surgeon go in there and look around and try to physically seal whatever the defect is. On the next slide is the medication that we've been utilizing to try to remove the iron deposits that are already there. So whether or not you have the opportunity to fix the bleed or not, the approach of removing iron from the surface of the brain is really what we believe is the fundamental approach to treating this disease. We have to get the iron off of the brain so it's not causing any more damage. Now, there is one medication so far on the market that can get into the brain and can bind iron, and this is called Deferiprone or Ferriprox. It's a very simple molecule. Within 7 minutes of absorbing it in your body, it's already in the spinal fluid, and it waits for the iron to be released by that ferritin protein. And as soon as it is, the Ferriprox can bind the iron, and then it remains soluble, and it goes right back into your circulation, and you eliminate it in the urine. And this is a medication that's been around in the US since 2012. When we started our first study with 10 subjects, we only tested it for 3 months back in 2010 before it was even approved. And we saw very, very mild effects on the MRI. Not many patients saw benefit yet. And we felt like we had to take it out to more than 3 months. And we did a 38 subject 2-year trial. And that's where we really started to see the improvements on the MRI. Now, the clinical improvements were harder to discern. A lot of patients reported stability, which is great because, even if we can't achieve healing, if we can at least stop the progression of the disease, that would be a worthy target as well. On the next slide, I have a list of treatments that we've tried and things that we've not tried yet that may be helpful. Things that we've tried are iron chelators that don't get in the brain. We know that they don't work. It's not like removing iron from the body will help. You got to remove the iron from the brain. We tried shunting the spinal fluid to see if we can drain the spinal fluid with all the iron in it and make it go into the belly instead of remaining in the spinal fluid, remaining within the skull. If we could shunt it out and allow the brain to just make more spinal fluid, maybe that would help. It didn't turn out to help very much. There are a lot of complications with that procedure. And then there are other chelators that are very effective to get into the brain, like triamterene, but they don't actually bind iron. They bind other metals, and those don't help. And of course, doing nothing does not help. It's a progressive condition. Now, there are other vitamins like inositol hexaphosphate, IP6, and curcumin that have been reported to be helpful and have the rationale to bind iron and get in the brain, but we haven't had the opportunity to test those yet. That's one of the things we would love to do. On the next slide, I just want to mention 3 projects that we're doing in superficial siderosis that I think are going to be very helpful. So slide 15, project number 1 is something that is very important to me because as a scientist, I want to know what is causing the disease in the brain, what is actually happening, what cells are dying, what is the iron targeting, what is actually going wrong. And to do this, we really need to see the tissue. We have to see the pathology under a microscope, take a look at it, see which cells are there, which cells are not, what the damage is. And that's harder than you think. The brain has the consistency of jelly. And in order to get some tissue with superficial from a siderosis patient, you either need to do a live biopsy, which we're just not going to do. We're not going to put someone through a biopsy procedure just for the sake of science. That's not ethical. And so the only way to do it is if they were getting a biopsy for some other disease, like a tumor or something like that. Maybe we could see some of the extra tissue. But more likely, this is going to be from autopsy material. And I just showed there an artwork, a Rembrandt, of what they would do in the Netherlands. Once every year, they thought it was ethical to take a prisoner who passed away, who was hung for some crime, and they would do a public autopsy to learn about a human body. And that's an example of art in medicine. And what we're trying to do is create a registry of patients who have superficial siderosis, and if they die from whatever the cause, stroke or car accident, God forbid, or whatever, then at least we would be able to get that tissue to the medical examiner's office, get those protocols in place to have the medical examiner prepare the brain and ship it to us so we can cut it, section it, stain it, look at it, and get an idea of what the disease process is. Believe it or not, there's not been a single report of superficial siderosis under the microscope. So that has to be project number 1. On the next slide is project number 2, which is to develop MRI protocols that are much better at quantifying the amount of iron. And let me tell you why this is important, because on the next slide, you'll see 2 MRI slides here. Again, the white arrows are pointing to the black iron. That's the schmutz that's stuck on the surface of the brain. Now, if I took a little bit of that iron off, I chiseled it off, the MRI wouldn't change because it doesn't give us any degree of thickness or volume. And because these MRIs were not designed to do that. MRIs were not really developed for superficial siderosis patients, but there are ways to do it. And I have colleagues in the radiology field who just need time, they need software, they need patient participation to get these images processed and to understand exactly how these iron levels change over time, so that when we apply a drug like Ferriprox and see if it helps, we need to be able to reliably determine if there's iron being chelated or not. And then in the third project on slide 18 is, you can see Ferriprox again. It's still too slow. We had 38 patients, and over 2 years we started to see improvements, but not as much as we would like. And so we're trying to expedite this iron chelation process. And one way to do that is to use a second medication at the same time that actually pulls the iron off of the ferritin, shuttles it to the Ferriprox, and then the Ferriprox takes it out of the body. Those middlemen, essentially, are called shuttlers. They're called iron shuttlers because they take the iron off of the protein and they transfer it to the drug. And one of them is now on the market for a platelet disorder, and that drug is called Promacta, and we're in the process of studying that one to see if the combination of the two, Promacta plus Ferriprox, would be a lot faster. There are always side effects and risks and concerns that we're also considering, but I think everyone would agree that waiting years and years and years for Ferriprox to work is just too long, so we need to find better ways to do it. And so I'd just like to conclude with the last slide and the acknowledgements of everyone in the lab who's working on these research projects, and of course the new Superficial Siderosis Research Alliance, Rory and Kyle and everybody who's been helpful, especially with the new the pathology project, the autopsy project, which is very meaningful to everybody, and I thank you for your support. Okay. So I just want to thank everybody again, and I'm always happy to take questions on Facebook and otherwise. So enjoy the dinner, and thank you all again. I really appreciate everyone's